Thank you, chairpersons. We now go to the most prestigious presidential lecture. And for this, I request on stage to be the chairpersons, Dr. Ramesh Sen, the President-elect of Indian Orthopedic Association, and Dr. Naveen Thakkar, Secretary of Indian Orthopedic Association.
So,
next slide, please, of introduction.
This is my
Dr. Anand
privilege
Peter.
to introduce and technically the president of this association right now, Dr. B. Shivashankar, to this gathering. We all know the last year, the kind of a progress and most important, the kind of a theme which he had to be Atmanirbhar. I think the concept was great. And then you look in that Atmanirbhar, going further to Atma, the self-care. And self-care, because if you are fit to work also. And taking care of yourself becomes the prime duty so that you can work for the society, you can work for the millions around you. And that is what Dr. Shiva is there. So, again, requesting Dr. Shiva.
It doesn't require much introduction. Dr. Shiva, please.
Good morning, everybody. Chairpersons, President-elect Ramesh Sen, sir, Honorary Secretary Naveen Thakkar. The IOA Presidential Lecture, the topic I have suggested for the theme is Atmanirbhar Orthopedics, Indian at Heart, Global in Competence. In the same line, the topic I selected to share with you is my little bit of contribution to the Atmanirbhar Orthopedics. Friends, I practice in a Tier 3 city called Solapur with less than 10 lakh population, no working airport. And today, whatever I am, it's entirely because of my academic work and little bit of innovations, and I thought I will share those little bit things with you all. The first and foremost which made me fame was Solapur technique or the tick-tick technique of interlocking. How the idea came? Even with C-arm, I had the pleasure of working with Dr. Iyer right from day one of my practice with a C-arm. In spite of having a C-arm used to break down majority of the time. That was the initial days in 90s. So we used to miss the distal locking or the proximal locking many a time because of the substandard implants also at that time available. So we were using the guide wire sounding technique. When I presented my first closed femoral nailing in 1994 at my Solapur Orthopedic Association meet, my friend Dr. S.M. Bandari, thanks to him, commented, "Shiva, you have the C-arm. Close nailing is your cup of tea, not everyone's tea." At that time, C-arm was very, very costly and it was not available with anybody. But I took his comments as a challenge and started working on that. The end result is the tick-tick technique. We were all doing the femur nailing in lateral position, and in the same way I extrapolated and passed by railroad technique the nail, keeping a similar nail of same size. We could measure the x-axis and the y-axis at the junction of anterior 1/3 with posterior 2/3, and by passing a guide wire from the canal of the nail with a K-wire inserted at the marked point, this guide wire used to touch, and that will cause, by feel, you could see the hole. Then by dancing of the K-wire, you could see. You can hear the sound tick-tick when you were sounding it, you could perceive the feeling of vibration and you could measure the length by conforming. Not by just AP and lateral picture. 5 ways I was doing this conformation. It was very, very useful where C-arm was not available then, but even when the C-arm breaks or to reduce the radiation, even today we use this technique. I conducted from 95 December onwards so many workshops. One of the major workshops, the first one was at Dr. Babulkar and his team organized in Kolkata, in Nagpur, as a Golden Jubilee celebration of their medical college in 1997. And since then, there is no look back. I have conducted over 700 workshops across India and few African countries and SAARC countries too. Bilaspur, Chandigarh, you can see the chairman sitting next to here behind me, Professor Ramesh Sen in 1997. Pune, even we came to Goa, the same place, the Goa Medical College in 1998, we conducted Professor Nachinolkar, we can see in the picture. Then Dr. Rajat Verma joined our team. Rajat Verma was from Indore, but now he's in London. So we conducted many more workshops subsequently. And to discuss our own problem in India about the interlocking, we thought that we should form an association, and that was in Jaipur conference. 3 of us sitting, Dr. Iyer, myself and Rajat Verma, we charted out the pathway for the nails. And the first national conference of nails was held in Indore in 2001, February, just after a month after the Indore Bhuj earthquake. Professor D.K. Taneja, the past president, Dr. K.P. Srivatsav, Dr. Iyer, Dr. G.S. Kulkarni, the future president of IOA, Dr. S.S. Babulkar, future president of IOA, D.K. Taneja, future president of IOA, all of them were there, and we formed the association. The ad hoc body was formed, where I was the founder joint secretary, with President-elect Dr. Naresh Agarwal and Sunil Kulkarni, other people, VP MIDA, all involved. Professor G.S. Kulkarni in 2002, the then President of Indian Orthopedic Association, installed all the office bearers at a glittering function in St. John's Medical College, from where Professor Mallikarjun Rao, I can see, Professor Isaac, I can see, thanks, we had a wonderful time with you then. Then nails went along with Dr. S.C. Goyal to Varanasi, where Professor Ajit Saigal, the future president of nails, conducted the conference. 2004, Nagi was there, the head of IOA president at Ludhiana. Dr. K.H. Senteti came for our conference in Pune as the president. In Coimbatore, Professor Mailwahan Natarajan was there. Goa, we were having the president-elect, Dr. Goyal himself, as the president of IOA. K.K. Pruthi in Agra conducted in 2008, where I took over the charge as the president and had my conference in Khajuraho. We went to Kolkata. We went to so many places. We went to Chennai. So we went to all over the India, and even it came to Solapur in 2016, where Professor Dr. N.S. Lad came as the chief guest for our conference. In 2006, we had planned for 200 people, but we had 500 plus registrations. We had to change the venue on the last day. Professor Mailwan Natarajan saw this. With the efforts of Dr. Professor Goyal, subspecialty recognition was given immediately to nails, and we had our first subspecialty meet in 2006 itself at IOACON, Delhi. Friends, if you ask me what is a major contribution in orthopedics, I still think that nails is the only association in the world which is discussing about the problems of nailing. There is no other subspecialty association. We have arthroscopy, arthroplasty, knee, left side knee, right side knee, shoulder, everything. But we don't have nails anywhere in the world. So the whole credit should go to nails to discuss our own situations. This is my greatest contribution. And because of that, today I am standing in front of you to give this prestigious lecture of IOA. The next contribution, Solapur sleeve. When I attended the interlocking nailing workshop at Coimbatore, this is a picture from the workshop. I saw that such a huge incision had to be taken to put the nail, and I decided to make the incision smaller by designing this Solapur sleeve. Initially, I used a proctoscope only. Then I used to call proctoscope, but then we patented it as Solapur sleeve. It could make the incision smaller, it could reduce the pain in the patient, it could reduce the mortality, and the patient could walk immediately after a good nailing because there was hardly any pain. You could see that such a useful instrument could be designed and patented in 1998. This is very, very useful, especially in a hefty patient where the soft tissue comes in the way. This was a bilateral case I had operated 19 years back in 2000. He recently came during the lockdown, such a beautifully healed fracture, and these are the pictures of him. Even for a distal femoral nail, again, distal femoral nail is coming back. The same sleeve can be used, and with that sleeve, one can make the incision small. Pain becomes very, very less. That's the most important aspect of that. With an incision as less as 2 centimeters, we can do the whole nailing. As I said earlier, for nailing, I went all over the India. I have gone to Visakhapatnam at least 6 times, and I have conducted live workshops all the 6 times. In one of the workshops at Government Medical College, Andhra Medical College, one Dr. Anil Satish, who was the lecturer then, suggested, Shiva, DHS is the bread and butter of orthopedic surgeon. You should have a keyhole technique for DHS. His words I took as a challenge, and I designed the instruments and the implants for the same. Not the implants, all the instruments were modified. The end result of the same is the keyhole DHS. I have done many demonstration surgeries. Can you believe that such a big implant can be inserted with a less than 2 centimeter? The whole videos are available on the YouTube. The patients are very, very comfortable because the incision is less, the morbidity is less. How I do it? I keep the blade plate on the body and mark the second and third hole. Keep a guide wire and take the lateral picture and mark it. Wherever these 2 lines meet, I take a small incision and insert this Solapur sleeve, which is 15 millimeter internal diameter. Through this, I pass the guide wire. Then with a double reamer, I ream. This double reamer incidentally became additional innovation because I didn't want the triple reamer to increase the size of the incision. And this can be used very easily. With the small incision, I have already passed the head screw in the head and neck. Now I'm using the plate as a periosteum elevator and inserting into the wound. Once the plate is inside the wound, you have to rotate and slip it over the screw which is already inserted. And then, by just retracting, as my incision is between second and third hole, by just retracting distally, you can put the fourth hole, and just retracting proximally, one can insert the first screw. I have done twice the demonstration at Ganga Hospital. That video is available on the YouTube, and you can search for Dr. Shivashankar to see the video. This is an example, fracture neck with fracture distal femur, 2 different implants, both inserted by keyhole surgery, DHS, and the supracondylar nail. One of my friend, Dr. S.P. Shah from Miraj, uses the similar technique, and these are some of his slides where he uses just a band-aid for these cases. The next innovation is a distal locking made simple, reducing the radiation to the hand. Friends, a carpenter was working in my hospital. We all know that in the red area is where maximum radiation happens. I took one of the baton which was thrown out by the carpenter, and I passed a K-wire and started using during the surgery so that my hand is away from the radiation beam. So since my hand is away from the radiation beam, automatically radiation to hand becomes less, and we could centralize this K-wire in the center of the moon. Nowadays, we get what you can see on the other side. These are the imported sophisticated distal locking K-wire holding instruments which are available in the market. This is a 96, 97 video. Friends, very old video. Friends, sometimes we get stuck up, especially canal removal is a difficult challenge. The problem is the hammer of the canal is very, very small. It's just 500 grams to 800 grams. So extracting a canal becomes difficult. So I designed a small instrument which can fit on one side to the interlocking nail extractor and the other side to the canal hook. So the hammer became heavier. 2.5 kg hammer, force with which we can extract is more. This is a cave nail which is antibiotic nails which are stuck up. Patient had undergone 2 surgeries. 2 surgeons had failed to extract it. Then he came to me. I took an X-ray to confirm that the eye of the canal is not damaged. Once it was intact, with my instrument, I could successfully extract. This patient brings every year at least 2 more new patients to me. A satisfied patient is much more better than you appointing your hospital promoters. So always treat your patient so that he is happy. Tell him that this is a very problematic case, and once he is convinced that you have done successfully case, then for the life he is indebted to you, and all the complicated cases he starts bringing. Next one is the Solapur Broken nail extractors. I extracted a broken nail with the head of the AMP head extractor, and I thought, why to open a fracture if it is not required? So I tested between 1999 to 2004 various metals. Thanks to Mr. Shivashankar of Shivashankar Orthopedics, he used to make all the changes and give varieties. This is one in between where the tip is attached and welded to the steel part, because the tip is having more carbons which breaks brittle like a drill bit. So this is a very interesting case. A doctor, he was operated in Mumbai. It had failed in spite of the bone grafting which was done. The nail had broken. He gave me a challenge. He said, "Sir, everybody has taken your name and I have come to Solapur for extraction of this. If you are able to extract without opening my fracture, please do it. If you want to open for any reasons, please don't open." He was not having confidence to get his thigh opened in Solapur hospital. This is the reputation of Solapur from where I hailed from at that time. That was the extractor I was using. Unfortunately, the extractor gave way. Friends, you can see my extractor extraction part, the tip is still inside the distal part, but my extractor broke. See the strength with which I have hammered out. The extractor broke, not the junction of the threaded portion with the nail. The reason was I had not removed a part of the broken distal screw which was still inside the nail, which prevented the nail to come out. So now what I did was I pushed the awl from knee, took out the nail without opening the fracture site, and then I did over-reaming and put a thicker nail. Fortunately, without any problem, the fracture consolidated. This is subsequently when he personally visited to show his thigh to me. So this is what is the final product which is available. Unfortunately, I could not patent this instrument. When I went to Delhi for patenting the instrument, they asked me, where are you used? I said, I have used with Dr. Kainar, I have used with Dr. Bandari, I have used with Dr. Kotadi, I have used with Dr. Manmat Raut. Then the people sitting on the other side of the table said, Dr. Shiva, have you patented your intention? I said, no. Since you are not patented this, the intention, we cannot patent it. Since then, I stopped patenting anything. Let the technology, whatever it is, let it be freely available to all. How I do this? Remove the proximal broken piece, over-ream the proximal canal. This is very, very important step. Always over-ream the proximal canal, then attach the distal extractor, remove the distal locking, then with minor hammering, extract the nail with the rotation force still on. Thanks to Dr. Tanna, he published this article in his Interlocking nailing book. Thank you very much, sir. The next one is an economical frame for distal end of radial fractures. Friends, we were all using a delta frame like this. Radial side fixation, ulnar side fixation, and cross-connecting both of them with another four. So we required almost 12 X-collab clamps and 4 connecting rods and 8 shank spins. Once I was operating at civil hospital, after applying the radial side, the assisting nurse said, sir, we don't have all the clamps which are properly fixing on the connecting rods. So what I did was, from the radial side, I removed one and I took it on the ulnar side. Another radial side one, I took it on the ulnar side. And Dr. Barve from Pune Hospital, he was assisting me. And he said, sir, there is one more which is still can be used. He said, we'll apply here, the 5th one. And the result in that patient was so excellent. Instead of 12 clamps, we had only used 5 clamps. In a government setup, you all know what the importance of reducing the amount of time you operate, reducing the number of implants. So this became a regular way of treating fractures in Solapur. Thanks to all my friends in and around. Even now, I get cases nowadays from even as far as Uttar Pradesh, Gonda. One Dr. Tripathi keeps sending me every now and then cases done with this Solapur technique. How I do it? We pass 2 shank spin in the second metacarpal base at an angle of 120 degree. It should not be less than 90 degree. That is the only thing. If it is less than 190 degree, it acts as a uniplanar fixator. It should be more than 90 degree. Similarly, in the middle third radius, we put 2 more shank spin, in the same angle. Give traction under anesthesia. Getting reduction is never a problem. Apply the fixator in whatever position you reduce it. You can give palmar flexion, ulnar deviation, everything to this. Such a badly comminuted fracture, you can see beautifully it anatomically healed at the end of the treatment. Another intra-articular comminuted fracture, again, the intra-operative X-ray and the post-operative X-ray. A bad wound where I cannot put a volar plate, again, I have used the same technique of putting an external fixator in this patient, and the patient has done excellently well. This is my neighbor. My house number is 6 and her house number is 4. I have to see the face of her every day. She came with a badly comminuted fracture. Again, I have used the same technique. You can see there is ulnar styloid process fracture. It's a unstable fracture. And you can see that he was able to use her hand for activities of daily living without any problem. And she is very happy. And there is full restoration of the anatomy of the distal radius. If you measure all these anatomical landmarks, it's a 100% restoration, clinically, radiologically, as well as functionally. I can show hundreds and hundreds of cases. Probably more than 1,000 has been done in Solapur itself. The next one is for large gap. We all use AO type of external fixator before the LRS became popular. But for humerus, this was a too bulky instrument or an implant. And this was a humerus where I was doing a bone transplantation in this patient. So what we did was, we were using the Elizero system, Rancho Cube of Elizero and the threaded rods of Elizero and the radius ulnar shank spins. I started using it and made a fixator in this form. We could transport the bone. We also did the study on cadaveric models and came to conclusion that by putting an additional pin, additional connecting rod, the stability of the fixation improves. And we have done many cases, especially in the forearm, the humerus. But unfortunately, I lost all the slides when I presented in 1995 in Pune, IOACON. Somebody had taken away all my slides. So I don't have all the pictures to show you. Here you can see fracture being compressed. And this is the same fixator which has been used. And this is a distal humerus was missing, where I used this technique for transporting the humerus to elbow, and then we fused with a ulna. This is the same happy girl with the transportation being done. Next one is the innovation need not be very big. It's a small innovation. When we used to put the percutaneous K-wires and apply plaster, while the time of removal of the plaster, many a time the K-wire used to run away or walk away with the plaster. The patient's relatives are always concerned. They think that something major mistake has been done by the plaster removing technician. So to prevent that, what I did was I designed a small Jess clamp which is round in shape, which can be used. This is a acromioclavicular dislocation where I have used this clamp. This is applied at the end of the K-wire so that the K-wire will not hurt the patient or it will not get stuck up in the dressing material. I have used it for n number of cases, all varieties. You can see a radial head fracture in a child. I have used a K-wire to reduce it and put at the end of the K-wire, I have put this ball. Distal end radial fracture, mallet's finger fracture, everything. Wherever you want, you can just apply this at the end of the exposed K-wire, and they do very well. This is outer end clavicle fracture. Again, I have fixed this with 2 K-wires, and this is after almost 20 years. Now, recently, during the lockdown, this patient had come. The next one is, I had lot of Asni screws available in our OT. And again, I asked Shivashankar, can you make use of this for something? Then he came out with this beautiful idea to have a bicompression screw. That was the time due to osteoporosis when we used to put the screw from one side and tighten. It used to lose the purchase and walk off. To prevent that, we started compressing from both the sides. Over a guide wire, you can see, over a guide wire, you pass the screw. There is purchase on one side, there is a washer from other side. When you tighten this, the fracture gets compressed beautifully. This is very, very useful implant, especially for condylar fractures of the tibia. This is a depressed fracture of the distal proximal tibia, where you can see the compression fracture has been used beautifully. You can see so much of compression could be done. This has got 1.5 centimeter long threaded end. So you can compress 1.5 centimeter, 15 millimeter of compression can be obtained with this. The same case you can see at the end of 3 months. Another badly comminuted proximal tibial fracture. Again, this is the slide of Dr. Kotadia where I used this technique, and you can see functionally the patient came with an excellent result. Another distal femoral fracture. Again, a similar condyles have been fixed through the plate. Instead of having a washer, I have used the plate itself as the washer, and this is a intermediate follow-up in this patient having about 100-degree flexion. Another depressed tibial condyle fracture. Again, you can see we have used bone graft as well as the screw. This is all prior to the availability of rough plates and other things, friends. This is all. What I'm talking is this X-ray is 2007. So all this we have used, and it has given us excellent results in these cases. This is the 14-month follow-up of the same patient with a restored knee joint. So this is the next innovation, which is Solapur screw. Recently, 2 years back, I had a problem with one of the patients. This patient, I had done spine surgery in 1995. Then I did HT1 in 1998. She underwent a TKR in Pune, and she had a fracture distal to the implant somewhere there because she had given all these X-rays for the reimbursement purpose. I don't have the X-ray. It was treated with a plate. Unfortunately, that plate was also not properly put, and you can see she was going for hypertrophic non-union. I treated this patient because already it was 1 year old. I treated with a locking plate, but since she had not walked on this leg almost for 2 years, bones were very, very soft. It was like butter. My screws were not having purchase. But in spite of that, I applied plaster. After 4 months, I removed the plaster. One day, she twisted her leg, and you can see the screws started walking out. Now, what to do? Either to put another plate with a knee prosthesis above. It was difficult for me to change it, and the bone is also very soft, though due to digital X-ray, it may not look as bad as this, as bad it was, but it was really soft. I plan to do additional plate as well as fix the same plate. I got special nuts prepared again through Shivashankar. I got special nuts prepared and for AO cortical screws. And I applied, you can see all these are the same hole without taking out. I just used a longer screw where the hole was become larger in size. I used a nut on the opposite side. I even inserted one nut below so that this part should not walk out. And unless your thread goes through the drain tube, you cannot pass through the wall of the drain a needle. So I always thought that the wire has to be inside. What I did was I started using thicker K-nails. Again, I used to pull the drain, and with the K-wire, I used to break the thread. This is one way of taking out the drain without opening. This was a spine case I had operated. Unfortunately, drain was stuck. You could see that without any problem, I could take this out just by pushing with the K-wire. Again, thanks to Dr. Tanna, he made this technique famous by his various presentations. Friends, these are some of the techniques or the things or the innovations which I have named as Solapur and which all of you have been following. I do get called, why did you name all of them as Solapur? Why not Dr. Shiva? When Dr. Daga is there, Dinel is there, you should have had Shiva's technique. That's what everybody says. Friends, I got the opportunity to work with so many people, Dr. Kotadia, Dr. Degavkar, Dr. Chidgupkar, Dr. Asit, Dr. Ganjale, Kairnar, Bandari, Sambaram, Swapnil, Manmat Rao, Dentkale, so many people, even Dr. Daga. I did my first THR in Dr. Daga's hospital. So, when Solapur has given me so many things, I came from Karnataka, I came as a son-in-law of Solapur, but in spite of that, they have accepted me as a Solapurian. I thought it's better to name this as Solapur. Similarly, the Maharashtra people accepted me as their own person, and I became the president of the Maharashtra Orthopedic Association. Now I am in front of you as the president of Indian Orthopedic Association only due to the love given by you all people, and I must thank all my patients, tall, short, ladies, young, senior, old, everybody I thank at the end of my talk. Last but not the least, I must thank my professor and my father-in-law, Dr. V.M. Meyer, because of whom I had a good working setup right from day one of my practice with CM and everything, arthroscopy, you name, we had it. We do one day plastering, one day joint replacement, one day spine. We are general orthopedic surgeons. The setup was so well equipped that I could that use as a platform, as a springboard for me to bring it to this stage. I thank you very much. I thank everybody for this opportunity. Thank you.
Hello. I think we have been able to see a great surgeon